Hello, everyone. Myself, Sandeep Sahu. I am working as a professor in Department of Anesthesiology, Sanjay Gandhi PGI, Lucknow. And I am taking perioperative fluid management and update. The learning objective shown in this slide, and we will discuss, especially focus on adult patient intraoperative management, how to give fluid, what type of fluid, and what should be the endpoint, what are the recent evidence and current concept for regarding fluid management. As we know that we have evolved as modern human from somewhere the apes, and with this evolve modernization come in 2020 and 21 in all aspect of anesthesiology, especially the perioperative fluid management has changed a lot. Earlier we are giving fluid management for the low hemoglobin, but now for the from normal saline to colloid to crystallite, we are moving towards pH guided resuscitation and balanced crystalline. Why we give fluid? We give fluid to restore and maintain tissue fluid and electrolytes, homeostasis, and central euvolemia so that it facilitates tissue oxygen delivery. We give fluid for resuscitation, and fluid is considered now like it is like IV medication or like antibiotic that should be given by protocol as per individual need, and it has been shown that by various recent researches that perioperative outcome improves with optimal IV fluid therapy. Why we prescribe fluid? हम देते क्यों हैं fluid? There are 5 R's that is shown by Melbrain et al. In an intensive care in 2020 that either we give for resuscitation or we give for routine maintenance after the resuscitation patient stabilization, or we give either replacement for ongoing fluid losses or because of redistribution to maintain the internal redistribution of fluid that occurring especially in the like ascites or in edema, or when we reassess our resuscitation whether fluid overload is there or still hypovolemia is there, or we to correct the electrolyte disturbance. These are the 5 R we give prescribed fluid perioperatively. To understand better, we have to go on the basics of IV fluid therapy, and we know that this as shown in the this diagram, we need euvolemia because there are two forms, hypovolemia and hypervolemia. In hypovolemia, because of hypoproduction, organ dysfunction can occur, and in hypervolemia, because of tissue edema and adverse outcome, the intravascular volume can hamper the management and causes complication. It's same like those who like to take the alcohol, and if you don't take the adequate amount, you will be not get the purpose is not solved for which you are taking alcohol. But if you take too much uncontrolled way, it can cause liver disease. To understand better that what we give as a fluid is not the blood. The blood, because we give fluid in the plasma, and we have in our blood the plasma and cells, and whatever we give in IV fluid, if it is similar to plasma, it will help the cells and the proteins there. But if it is not like plasma, it will alter the internal milieu, because we know that plasma has different protein and electrolyte and different things that is needed for transportation and for making life. But definitely IV fluid that we give is not the plasma, it's different. And we think that we know that the compartment model of body, that 60% of total body water, there are the two compartments, intracellular and extracellular. Intracellular, the mainly it is having the potassium and proteins inside, more magnesium, calcium, and extracellular is further divided in interstitial and the plasma. And whatever, because this compartment is very important, because whatever losses occur, it occur in the extracellular space. Our aim is to replenish this extracellular space. We first, the losses occur at the plasma level and followed by the interstitial fluid. and potassium is more intracellular. We know that, and extracellular is the sodium ions. To understand more better in this, as in this slide, we see that intracellular is keeping inside the cell, and extracellular is either interstitial in between the cells or plasma. Plasma is in the intravascular, that is intravascular space that's shown in this figure, this the the arterial and the venous system. And the movement first occur from intravascular this plasma. This is first lost, we replace it, and if we are managing at this level, the cell can regenerate because we are not depleting the interstitial and intracellular. So whenever there is fluid is lost, or fluid is the blood is lost, the intravascular space, the plasma take fluid from the interstitial space, and when interstitial is lacking, it takes fluid from the intracellular space. And when intracellular fluid, we never want this to happen, because that is the life of a cell and organ, and if it is not there, it can cause cellular dehydration and cell can die. But whenever the intravascular compartment is less, it causes decreased perfusion and hypoxia at the peripheral level. It can hamper the organ function. Another concept beside this compartment is important, is the endothelial glycocalyx. Endothelial glycocalyx is a protected layer in between the intracellular and the at the cellular level, the intracellular and the extracellular space, and at the interstitial and at the junction of the at the intravascular level, where the plasma occur. And when it is intact, it is not allowing too many substances that should not go out or should not go in. But when it's very simple to understand, when it is damaged there because of so many things, then the permeability changes, and ion transport and the protein transport across or cellular transport across is altered. And when it is damaged, we can't able to give much fluid, because this fluid go and collected in the interstitial space. And with this concept, the recently a review published in Indian Journal of Anesthesia on this endothelial calyx, they have shown that if you are giving normal saline, it go into any fluid we give, it goes in the intravascular space, and it expand the extracellular space, and it remain here for like 1 hour, and it after that it is metabolized, after that it is utilized, metabolized, and excreted by the urine, because it goes to the kidney. And whenever the fluid is shift from intravascular to interstitial space, there are lymphatic channels that reabsorb the fluid, and they come, that absorbed fluid come through the lymphatic in the circulation. What happening when uh, the endo that glycocalyx is damaged? Because of in intravascular compartment, there is low colloid oncotic pressure, because protein is going through this damage, and there is changes in the colloid oncotic pressure, and the pressure that is keeping bind the protein inside and cells inside. Now that changes, so it changes. So now there is coming more fluid in the interstitial space, and that is not able to clear by the lymphatics, and it produces edema. So if it is damaged, it is not very good for the process of the fluid that we give, and we can't give much, because now that there is more damage, it will go more in the lung, more in the brain, and definitely the organs where it should not go, and will retain here. Uh, this is the a review that published in the BMJ, and where they say that how the body fluid compartments, the blood volume and theoretical distribution occurs in healthy people. So if we see the glucose in green, that especially go in the intracellular, when we give 1 liter, it goes 600 ml here. But what happens when we give the colloid? The colloid expand the plasma, so it mostly come here in the plasma. But when we give balanced salt or normal saline, uh, mostly it goes in the interstitial and lymphatics. Small amount going intracellular. So same has been shown in the IJ 2019 also review that dextrose containing fluid is not good because till then there is no need of nutrition because they especially go in intracellular. They don't go in plasma interstitial, though, so they don't expand it and they don't retain the fluid here. But cola definitely is considered a very good volume expander for years because they go in the plasma, they increase the intravascular compartment, they remain here more time as compared to the crystallite we give like NS or ringer lactate or balanced salt solution that mostly goes in the interstitial and partly go in the plasma. So this is important to understand how we give fluid and how they go in different spaces. And if the endothelial is damaged, then this endothelial partition will alter the movement of water from one compartment to another, and it will be deleterious. What is the classical approach of fluid management? If we see the classical approach of fluid management, that we predict the amount of fluid needed based on the duration and severity of a particular operation, and that we do, I think, routinely. We are also doing it earlier, but nowadays we have changed with the concept that is coming, and we are practicing it differently. So we calculate fluid losses prior to start of anesthesia, either because of bowel preparation, nausea, vomiting, or obstruction. The maintenance requirement, how many hours the patient is NPU. The normal fluid losses that occur during surgery or blood loss occur during surgery, then we consider titrating fluid according to the physiology, the blood pressure, CVP, and urine output. And we got this 4 steps. How we do it? Calculate preoperative fluid losses, the NPO duration. Then we take it 4 to 1 rule, Holiday-Sanger formula. And Holiday-Sanger formula is not meant for intraoperative blood loss. It is given in 1950 for pediatric diarrhea, 4 to 1, first 10 kg, then 10 to 20 kg, and more than 10 kg. The another step we calculate ongoing maintenance requirement is based on the patient weight and the same using formula 4 to 1. And then we calculate the surgical fluid losses depend on the minimal tissue handling or moderate tissue handling, surgery or trauma, or severe tissue handling or trauma or surgery. So depend on minimal 2 to 4 ml per kg per hour, moderate 4 to 6 ml per kg per hour, severe 6 to 8 cc or ml per kg per hour. Then we adjust for the anticipated fluid loss. Like for 1 ml blood, we give 3 ml of the crystallite, sensible and unsensible, the whether it is respiratory or the skin losses we calculate. And now we add all this, and on the basis of this all calculation, we give fluid. But do this calculation fit to all? Means all age group, all weight? No, because one side we can't fit to all patient, all type of surgery, all high risk patient. Other concept that we know from the years that there is third space loss, and we have to give fluid to compensate this. But when the researches has been done based on the various tracer and dyes, और ये देखा गया कि it doesn't exist because they don't go in third space, and there is no obvious existence of this third space. The classical third space quantitatively does not exist. So if doesn't exist, so when we give fluid, where it goes? It overload the patient because it goes in excess amount. So we have to give fluid, either we have to manage the intravascular compartment or the interstitial, the extracellular part, so that there is not occurring the intracellular hypotension, hypoxia, and dehydration. So there is a danger associated with arbitrary fluid administration that we are doing day and night by this method. This has been shown by the FEAST trial. FEAST trial is a fluid expansion as supportive therapy study that published in NAGM 2011. More than 3,000 pediatric patients, critical ill, they have given boluses of normal saline 30 to 40 ml per kg, albumin bolus or no bolus. The mortality death at 48 hours was around 10% in which the bolus has been given, as compared 7% in which bolus has not given. 4-week mortality was also more, around 12%, in which the bolus has been given, and were less, around 8%, in which bolus was not given. So definitely when we giving bolus based on the classical calculation, this arbitrary food administration is dangerous because it is causing fluid overload by this liberal fluid therapy. This is the liberal fluid therapy. And we know that if the duration of surgery is too much and you have given 5-6 liter of fluid in a 6-hour surgery, in nowadays when the loss is not that much, and we don't, and we see the conjunctival edema in post-operative period, patient is not able to extubate because the fluid is there, excess fluid is there. And especially in abdominal surgery, when we see the abdominal compartment syndrome, that is causing gut hypoperfusion, it having decreased venous return, it has diaphragmatic splinting, and all gut ischemia, gut overload and gut edema, and because also retraction of surgery, so much duration of surgery, and this hamper the either blood supply of the bowel edematous can reopen, then we leak can be there in anastomosis, and outcome is not good. These patients are going to stay more in your ICU. The cost of care is going to increase. So we have to avoid traditional liberal or fixed volume approach. There is, because there is a lot of edema and lot of and no third space loss is there, as we are considering earlier. So this is inappropriate, and it is well established that we don't have to give fixed volume. So one concept is that, then which fluid I have to give? We know that we are either using normal saline or ringer lactate or balanced salt solution. Dextrose containing fluid is not for the intraoperative use, and they, because 10% or more is hypertonic, uh, 5% are hypotonic, and they are only for nutrition. The normal saline is not normal because it only have the sodium and chloride. It's isotonic, but higher sodium and higher chloride is not good because this is causing hyperchloremic acidosis. The ringer lactate is considered to be the balanced, but it's slight hypotonic, and it has lactate that can cause problem specific patients because lactate is metabolized, and it can cause metabolic alkalosis in some patients, and lactate is not able to metabolize excessive load, especially in the liver disease patients and the hypotensive hypoxic patients. And the plasma light is considered to be ideal because the balanced salt solution. So because now we understand that the fluid that is isotonic is good. So either we are practicing I think in India, because in Western world now they have only isotonic fluid, balanced salt solution for perioperative use. But in developing country, still the market is like that. We have to consider that we have to use isotonic because the plasma constitute is shown here, and the normal saline is having the high chloride and sodium. The ringer lactate is having lactate 28, that is maybe if you are using more than 1 liter or NS or ringer lactate in 24 hours, especially the shock patients, the kidney dysfunction patient, uh, and ICU patients, then they can not able to metabolize all this, and we see excess of sodium and chloride and acidosis there. But balanced salt, if you see this, chloride is almost equal to plasma, sodium almost equal to plasma, potassium is almost equal. The bicarb and this is being taken care by the acetate and gluconate here. They have the magnesium, and uh, also the balanced salt is coming with the calcium. So there is still a controversy that which is best, but there is safe trial, crystal trial, chest trial, and elbows trial. I will say uh, the best is definitely the balanced one, balanced crystallide or polide. Don't use more than 1 liter ringer lactate or normal selenium, if possible in Indian setting. But nowadays the literature and the recommendation is that if we are using balanced salt solution is the best. Dextrose containing only for the nutrition. But what regarding colloid? We consider that they remain intravascular space for higher time. Uh, but what is the evidence? Recommended perioperative use in normal patient, those don't have the hypovolemia or any type of shock. No, if the patient don't have the AKI or renal dysfunction, it can be used uh, if we are not, if we have to give more crystallite to save that because the colloid to be given in lesser, but heta starch is not to be used nowadays. Only tetra starch with balanced tetra starch colloid perioperatively can be used, especially if there is no shock and AKI. If we have to use, then it is very safe to use the albumin because a lot of trial has shown that this is a natural occurring and it has also renoprotective effect. Only concern that albumin can be given, not be given in the traumatic brain injury patients. And European market, the European Medical Agency, they have abolished the heta starch use since 2013, and they say it is contraindicated to give it in especially the septic patient and trauma patient because of coagulopathy and the AKI. So colloid, they can have the volume overload, side effect, coagulopathy, anaphylactic reaction, interstitial edema. But there is this report that published in Anesthesia Analgesia, they say that after a few hours, they come from intravascular to extravascular and they accumulate there and so there are risk of edema because of use this. And also Cochrane database review say that there is no evidence that they are reduce the risk of death. So, and don't improve the survival also. So you have to be wise to use crystallite and colloid in a specific fluid that you have to use in your patient, which patient fit in, and you have to buy pro and con and have the risk and benefit ratio. Regarding approach to fluid management, we have already discussed that traditional liberal and fixed volume approach is not appropriate. What we should use in day and night routine surgery, we are using like those are having minimal and moderate invasive surgery. It is safe, and if the duration is like up to 2 hours of duration surgery, say 1 to 2 liter of balanced salt solution is good to because there is not much significant fluid shift and blood loss, and this fluid further can be reduced, especially in when there is heart failure and the COPD patients. And and in this type of, these are the routine surgery, 2 hour duration, normal patients, not much fluid lift, laparoscopic surgeries or open surgery that are not having much fluid shift and the blood loss, then that we are practicing. So ये वही patient हैं जो 80-90% हम शायद routine में रोज करते हैं. But what about the major invasive surgery? Liberal is a big no nowadays. So major invasive surgery, the approach should be either restrictive zero valence approach or a goal directed. These all has minimized fluid administration. It's not कम देना है, targeted देना है, guided देना है, goal देखते हुए देना है. At least ABG, lactate, pH, इलेक्ट्रोलाइट, जो हम रूटीन एबीजी एक 6 घंटे की सर्जरी में, जैसे हमारे एसजीपीजीआई में एक ट्रेडिशन है कि हम लोग बेस लाइन करते हैं, फिर हर 2 घंटे पे करते हैं. अगर ब्लड लॉस ज्यादा है या फ्लूइड शिफ्ट ज्यादा है तो हम वी कैन रिपीट आवरली आल्सो, डिपेंड ऑन व्हाट टाइप ऑफ सर्जरी वी आर डूइंग. सो अगर मेजर सर्जरी और एक्सपेक्टेड ब्लड लॉस 500 ml के से ज्यादा है, तब ये देखा गया है कि रूटीन जो हम हेमोडायनिक मॉनिटरिंग कर रहे हैं, CVP arterial is not enough. We have to go further. We have to go advance. And अगर हाइपोटेंशन होता है तो हमको ये भी देखना है कि हाइपोटेंशन क्या केवल ब्लड लॉस फ्लूइड शिफ्ट के मारे है या बिकॉज ऑफ एनेस्थीसिया. बिकॉज एनेस्थीसिया इज all agents are they are doing after induction or after regional block, we see that is there occur vasodilation और almost all patient hypotensive हो जाते हैं. So we have to take care कि blockage, अगर न्यूरोक्सिल blockage use कर रहे हैं तो सोचें कि कितना हाइट ऑफ ब्लॉक दे रहा है, कितना वॉल्यूम देना है, कितना लोड करना है, कितना लोकल एनेस्थेटिक देना, और अगर जीए दे रहे हैं तो दैट्स अगर पहले 1 घंटे में अगर पेशेंट हाइपरटेंशन नहीं हो रहा है in all surgery means we are doing good, because if hypotension occur we have to give fluid, and once we are starting giving fluid then where it will stop. So zero balance is a type of restrictive. Here only the fluid that is lost during surgery is replaced. uh, this is the strategy. So balance salt solution 1 to 3 ml per kg per hour देते हैं. There is no fluid overloading at the time of induction, no loading that we are doing in the liberal approach, and we avoid extreme deep anesthesia because that causes vasodilation. और अगर ब्लड लॉस हो रहा है और अलाउबल ब्लड लिमिट में है तो 1:1 या 1:1.5 क्रिस्टलाइट देने की जरूरत है, ना कि 1:3 जो हम पुराने जमाने में दिया करते थे. Other is goal directed therapy, and goal directed therapy means intravascular status we have to optimize before using any vasopressor if hypertension occur. And here goal directed therapy we are measuring advanced hemodynamic, and on the basis of we are giving fluid boluses, and especially it is has shown that major invasive surgery high risk group patient when the allowable blood loss is more than 500 or 1 liter or prolonged duration surgery, it has been superior to the traditional approaches. But there is also a lot of new studies to be done comparing restrictive fluid therapy with the goal directed, because this is still not very certain, and too much on this topic will be taken care by my colleague today. I want to say that enhanced recovery pathway that is for last 12 year practice worldwide, the individualized goal directed fluid therapy is the most important part. And this has been seen that when we are doing the major surgery, we are using the ERAS pathway with goal directed fluid therapy. The in the if we are this is the excess their fluid, and it is the time when the duration of surgery, like the traditional surgical pathway versus ERAS surgical pathway. In traditional and ERAS, both initially after induction or just at the start of surgery, initially there is a hypotension, but hypotension is less in ERAS surgical pathway as compared to classical surgical pathway or classical fluid management. But as the duration of surgery uh, going to increase, in ERAS pathway, the intravascular compartment and normovolemia maintained. But in traditional surgical pathway, either there is hypoperfusion of because of more hypotension, or there is more edema and fluid retention, uh, as we see in the blue line as compared to the orange line. So this study that is published in New England Journal Medicine in 2018, especially the major abdominal surgery, how we should give fluid and how should we do manage hemodynamic management, that is relief trial, in which the 1500 patient has been given restricted fluid volume around 3 liter, and the liberal fluid where we have given around 6 liter in 1500, so 3000 patients, and they have given an allograft. An allograft is this: when the patient has low risk and surgical risk is also less, then goal directed fluid therapy is not needed. But when the patient is high risk, surgery, then we have to go do the goal directed therapy. And when there is high risk surgical patient with high comorbidities, cardiorespiratory, elder age, and the high surgical risk means complicated surgery, then it is better to keep this patient in surgical ICU, because they're saying that post-operative phase is also important, and ERAs also going from pre-intra and to post-op. We are limiting all the IV line, the nasogastric tube, the urinary catheter drains in the post-op, and as early as possible, we have to start oral therapy as compared to IV therapy and ambulate the patient. So the perioperative fluid management approach is before surgery. It not say that we have to preload patients. It's discouraging nowadays, and because of we say that it will do less hypotension. But if you are giving right neuroaxial block and you are practicing the balanced general anesthesia, and if you are using all your experience, then there will be hypotension. Because if hypotension, then we either give more fluid or we use the vasopressor therapy. Intraoperative, we should use restrictive or zero valence goal directed fluid therapy. Postoperative, avoid positive net fluid balance. So recommendation for fluid therapy in major surgery, we have to minimize preoperative fasting. If we don't have the fancy monitoring, at least passive leg rest test should be done before giving to check the responsiveness of fluid. Aim is that moderate liberal IV fluid for means to be given, and you can have 1 to 2 liter of positive patient at the end of long surgeries. Ensure intravascular volume status first before giving vasopressor therapy, and use advanced hemodynamic monitoring, especially in high-risk surgery and high-risk patients. And it's unclear that which is better, crystallite and colloid, but balanced is better. And ambulate early as possible your patients, and give shift in the oral therapy. The future perspective, that is either closed loop hemodynamic management, means uh, the the advanced hemodynamic monitoring waveform going in the monitor that attached with a computer and artificial intelligence control device, and that controls the infusion pumps and vasopressor, and depend on what is needed, it give itself. And it has been proven better as compared to the traditional anesthetics when the people have done the study. And if do you closed loop is not there, then there is coming the individualized hemodynamic management, goal directed fluid therapy. One size fit all approach means it personalized, depend on the biometric factor, the age, the body weight, the height, the type of surgery, the comorbidities of the patient. So these are the two future that therapy that is coming for the fluid management. So very right, if we have one size doesn't fit well, we should have different size for different type of patient, high risk or low risk, long duration surgery or short duration surgery, more fluid shift, less fluid shift, more blood loss, less blood loss, higher duration, uh, big open surgeries, or long laparoscopic surgeries. Because sometimes they say laparoscopic, but it is like 12 or 24 hours when the new surgeon start laps bipples. So my take home message with this discussion, that tissue perfusion U is important by maintaining euvolemia, avoid hypo and hypervolemia. And this is not simple term. We have to do monitoring for that. Absolute or relative hypovolemia can be common in perioperative period because pre-op dehydration, so avoid it. Uh, Less NPO, or when you are using either because of blood loss or the because of anesthetic interaction of the drugs or central neuroaxial blockage. The most operative common cause of perioperative tissue edema is fluid retention. And the classical monitoring that we are doing, the blood pressure, heart rate, CEP, and urine output, is not very perfect. If especially if there are long duration surgery, the complicated surgery, then significant intraoperative reduction in tissue perfusion may not be recognized early, or because, and it is evidence shows that blood pressure guided fluid therapy is not optimal. We have to use the flow based, and that flow based hemodynamic monitor that improve perioperative outcome. Crystallite or colloid, definitely which or combination, but balanced is better as compared to the historical one. And 1 to 2 liter balanced salt solution for mild to moderate surgery is always better as compared to if you are using normal saline or colloid. For maintenance therapy, we can use 1 to 3 ml of balanced salt solution ml per kg per hour. For volume therapy, 250 ml of volume challenge is enough whenever you are finding hypotension is there. And minimal to moderate invasive surgery. We can keep early post-operative ambulation, and we can keep 1-2 liter of positive of the fluid intra period, especially if you are giving balance salt solution. The major invasive surgery, we should follow the restrictive or goal directed fluid approach, because that has shown for last 10 years so many study. We don't need to do a study in even in Indian population. If we are using restrictive balance approach, we are giving fluid only to manage the replace the fluid that is lost during the procedure. And gold dilated fluid therapy is invasive monitoring of dynamic hemodynamic parameters, especially for high risk patient when the allowable blood loss is more than 1 liter, significant non-hemorrhagic fluid shift is there, or because it gives the responsiveness, especially in long duration surgeries. So these are very change the outcome of the patient, decrease the hospital stay, the decrease the complication, decrease the ICU stay, and decrease the cost. So thanks for active listening. It is very important, my dear friends, to give the right fluid in right dose to right patient at right time. Thank you.